Hello everyone, today we'll be talking about diabetic ketoacidosis. The first thing that we need to know about this is that diabetic ketoacidosis is a medical emergency. So we need to pay a lot of attention to the topic, to the diagnosis, the management and the subsequent management too. So diabetic ketoacidosis, which is commonly known as DKA, is the hallmark of type 1 diabetes. It is usually seen in the following circumstances: previously undiagnosed diabetes, interruption of insulin therapy, and the stress of intercurrent illness. The majority of cases reaching hospital could have been prevented by earlier diagnosis, better communication between patient and doctor, and better patient education. The most common error of management is for patients to reduce or omit insulin because they feel unable to eat owing to nausea or vomiting. This is a factor in at least 25% of all hospital admissions. Insulin may need adjusting up or down but should never be stopped. Pathogenesis of diabetic ketoacidosis. Ketoacidosis is a state of uncontrolled catabolism associated with insulin deficiency. Insulin deficiency is a necessary precondition since only a modest elevation in insulin levels is sufficient to inhibit hepatic ketogenesis, and stable patients do not readily develop ketoacidosis when insulin is withdrawn. Other factors include counter-regulatory hormone excess and fluid depletion. The combination of insulin deficiency with excess of its hormonal antagonists leads to the parallel processes. So this is basically a diagram that's showing how we get impaired excretion of ketones and hydrogen ions. So increased glucose leads to hyperglycemic glycosuria, which leads to osmotic diuresis, which leads to fluid and electrolyte depletion, as well as increase in ketones leads to acidosis, which leads to vomiting, which leads to fluid and electrolyte depletion, due to the renal hypoperfusion, and which leads to impaired excretion of ketones and hydrogen ions. In the absence of insulin, hepatic glucose production accelerates and peripheral uptake by tissues such as muscle is reduced. Rising glucose levels leads to an osmotic diuresis, loss of fluid and electrolytes, and dehydration. Plasma osmolality rises and renal perfusion falls. In parallel, rapid lipolysis occurs, leading to elevated circulating free fatty acid levels. The free fatty acids are broken down to fatty acyl-CoA within the liver cells, and this in turn is converted to ketone bodies within the mitochondria. So this is basically a diagram that's showing ketogenesis. This is triglycerides from adipose tissue are broken down to free fatty acids. Then they're converted to acetyl-CoA, which is broken down to acetoacetate. Acetoacetate breaks down into acetone and beta-hydroxybutyrate. Hence, we have our ketones formed. Accumulation of ketone bodies produces a metabolic acidosis. Vomiting leads to further loss of fluid and electrolytes. The excess ketones are excreted in the urine but also appear in the breath, producing a distinctive smell similar to that of acetone. Respiratory compensation for the acidosis leads to hyperventilation, graphically described as air hunger. Progressive dehydration impairs renal excretion of hydrogen ions and ketones, aggravating the acidosis. As the pH falls below 7, pH-dependent enzyme systems in many cells function less effectively. Untreated severe ketoacidosis is invariably fatal. So, clinical features of diabetic ketoacidosis. The features of ketoacidosis are those of uncontrolled diabetes with acidosis, and they include prostration, hyperventilation, which we commonly call cosmal respiration, and is kind of pathognomonic for DKA, nausea, vomiting, and occasionally abdominal pain. Some patients are mentally alert at presentation, but confusion and stupor are present in most severe cases, up to 5% present in coma. Evidence of marked dehydration is present and the eyeball is lax to pressure in severe cases. Hyperventilation is present but becomes less marked in very severe acidosis owing to respiratory depression. The smell of ketones on the breath allows an instant diagnosis to be made by those able to detect the odor. The skin is dry and the body temperature is often subnormal even in the presence of infection. In such cases, pyrexia may develop later. Diagnosis of diabetic ketoacidosis. This is confirmed by demonstrating hyperglycemia with ketonemia or heavy ketonuria and acidosis. No time should be lost and treatment is started as soon as the first blood sample has been taken. Hyperglycemia is demonstrated by dipstick while a venous blood sample is sent to the lab for confirmation. Ketonemia is confirmed by centrifuging a blood sample and testing the plasma with a dipstick that measures ketones. Handheld sensors measuring beta-hydroxybutyrate in 30 seconds are available. An arterial blood sample is taken for blood gas analysis. The severity of DKA is assessed as follows. One or more suggests severe DKA. So clinical features are pulse greater than 100 beats per minute or less than 60. Systolic BP less than 90 mm mercury. Glasgow Coma scale of less than 12 or abnormal allied voice pain unresponsive scale, which is AVPU. Oxygen saturation less than 92% on air if normal respiratory function. And then blood ketones greater than 6 millimoles per liter, bicarbonate less than 12 millimoles per liter, venous arterial pH less than 7.1, hypokalemia on admission, which is whereby the potassium levels are less than 3.5 millimoles per liter. Management. The principles of management are as follows. This should be carried out in a high dependency area. So you replace the fluid losses with 0.9% saline. Average loss of water is 5 to 7 liters with a sodium loss of 500 millimoles. Replace the electrolyte losses. Patients have a total body potassium deficit of 350 millimoles, although initial plasma levels may not be low. Insulin therapy leads to uptake of potassium by the cells with a consequent fall in plasma potassium levels. Potassium is therefore given as soon as insulin is started. Then restore the acid-base balance. So the first thing we're doing is replace the fluid losses and replacing the electrolyte losses. The next thing is to restore the acid-base balance. A patient with healthy kidneys will rapidly compensate for the metabolic acidosis once the circulating volume is restored. Bicarbonate is seldom necessary and is only used if the pH is below 7 and is best given as an isotonic 1.26% solution. Replace the deficient insulin. Relatively modest doses of insulin lower blood glucose by suppressing hepatic glucose output rather than by stimulating peripheral uptake, and are therefore much less likely to produce hypoglycemia. Insulin and glucose together both inhibit gluconeogenesis and thus ketone production, and are needed to metabolize ketones into less harmful substances. Short-acting insulin is given as an IV infusion where facilities for adequate supervision exist as oral intramuscular injections. The subcutaneous route is avoided because subcutaneous blood flow is reduced in shocked patients. Monitor blood glucose closely. Seek the underlying cause. Physical examination may reveal a source of infection such as a perianal abscess. Two common markers of infection are misleading. Fever is unusual even when infection is present, and polymorph leukocytosis is present even in the absence of infection. So relevant investigations that can be carried out include chest x-ray, urine and blood cultures, and an ECG. The serum amylase may be elevated in the absence of pancreatitis. If infection is suspected, broad-spectrum antibiotics are started once the appropriate cultures have been taken. So this is basically the guidance for the diagnosis and management of DK that we have just talked about. But you could read this if you're in a hurry for a brief summary. Problems of management. So what are the complications of management? Hypertension. This may lead to renal shutdown, plasma expanders, or whole blood are therefore given if the systolic blood pressure is below 80 mm mercury. Coma. The usual principles apply. It is essential to pass an NGT to prevent aspiration, since gastric status is common and carries the risk of aspiration pneumonia if a drowsy patient vomits. Cerebral edema. This is a rare but serious complication and has mostly been reported in children or young adults. This is due to excessive rehydration and use of hypertonic fluids. Hypothermia. Severe hypothermia with a core temperature below 33 degrees may occur and can be overlooked unless a rectal temperature is taken with a low reading thermometer. Late complications include pneumonia and deep vein thrombosis. They occur especially in the comatose or elderly patient. So complications of therapy include hyperglycemia and hypokalemia due to loss of potassium in the urine from osmotic diuresis. Over-enthusiastic fluid replacement may precipitate pulmonary edema in the very young or the very old. Hypochloremic acidosis may develop in the course of treatment since patients have lost a large variety of negatively charged electrolytes, which are replaced with chloride. The kidneys usually correct this spontaneously within a few days. Subsequent management: intravenous glucose and insulin are continued until the patient feels able to eat and keep food down. The drip is then taken down and a similar amount of insulin is given as 4 injections of soluble insulin subcutaneously at meal times and a dose of intermediate acting insulin at night. Sliding scale regimens are unnecessary and may even delay the establishment of stable blood glucose levels. The mortality of DKA is around 5% and is increased in older patients. Its treatment is incomplete without a careful inquiry into the causes of the episode and advice as to how to avoid its recurrence. So that's all about diabetic ketoacidosis. If you like the video, please like, subscribe, and comment. Thank you.